So guys, my name is Sam Elder, one of the faculty here at the PA program, OUHSC. Again, kind of keeping on with what we've been talking about, more emergency medicine stuff. So we've kind of gotten what you bring with you to the emergency department. Now, this is more of what you've got with you whenever you're there, hopefully. And now there are always different places, different locations. If you ever do go out and practice in a rural area, you may not have all of these things. You may have some of these things. You may have none of these things and only have what Professor Claypool had in her bag. So we're going to try and walk through a lot of these things. Some of them mix and mash between one another because you've got medications and interventions, and a lot of times these things happen all at once. But hopefully this will give you an idea of different airway stuff, different medications, ways to administer. And the big conversation that Professor Claypool has always brought up was knowing the difference between an angiocath and a Foley catheter. And there, hopefully you'll really understand the differences between those two whenever we get rolling. So whenever you have someone who comes in from an EMS service of any kind, a lot of times, they may just roll in and have general complaints, no big deal, but sometimes there will be emergencies that require some type of immediate intervention. And most of the time, whenever you think of CPR stuff, we talk about airway, we talk about breathing, we talk about circulation. So the ABCs of sort of that emergency encounter. So if we're talking about airway, we're talking about breathing, assuming that they are one and the same for simplicity's sake. There's a lot of different tools that you can use to try and keep that airway open. So if we're assuming that somebody is still awake, they're still conscious, but they're having trouble breathing, we think that maybe they're having trouble getting oxygen. One of the things that we can actually use kind of in our kit of tools on a truck even, and actually I want to use this one, is a non-rebreather. And so what this does is a type of mask that fits over the head, behind the head, and fits over the nose and the mouth to help provide some oxygen and help with the airway. Whenever you connect this piece of equipment, you actually will hook it to either an oxygen tank, or if you're on the truck, you'll hook it up to whatever their system is. Or if you're in the clinic setting or the emergency department, this will be an oxygen thing on the wall. Plug it up, max it out, and then you'll put this on your patient. The little bag will fill up, and that's just going to be where oxygen is kind of hanging out there. And that will mix with room air, but it supplies an increased concentration of oxygen to help that patient breathe, assuming that they're moving air and it's just an oxygen issue. There's a couple of different types of these in existence. So that's one. This one actually has a way of measuring liter per minute. So it actually has a little dial on here that you can adjust that oxygen concentration and the rate at which is going to the patient. So if you had someone who was CO2 dependent, so if you have a COPD person or COPD patient who chronically has a low oxygen saturation, but they're struggling, you can actually give them too much oxygen in one shot. And so really this helps you manage that a little bit in a more controlled setting. If you have a patient that you have that is, say, unconscious, or they're not breathing on their own for whatever reason, they have an acute heart attack, or they have something else going on, but they're not initiating that breath, but they have a pulse, you may have to do a little bit of breathing for them. So this is actually called an Ambu Bag or a breathing bag, or there's a lot of different names for it, but it comes in kind of a couple of different parts. One of them is the mask. And so this is what will fit over, again, the nose and the mouth of the patient. It's got a little soft air, so it'll help seal. And then that connects directly to the bag. And so what this will do is create a positive pressure environment whenever you squeeze, and then it won't suck air back. It allows the patient to breathe that out, and it's expelled out through the other end. Oxygen is hooked up to it here. And then whenever you do this, you actually don't squeeze the whole thing out either, because a lot of times whenever students start this and they do their first code, they get really excited and they start doing really rapid breathing. So really it's just regular rate, so about 5 to 6 per minute. Actually, excuse me, that's going to be 6 to 8 per minute. Sorry, I got excited myself. So, and that will help you initiate that breathing for them. So the other thing is, if you have a situation where this patient is not maintaining their airway, or you really need to be able to free your hands up to do something else, and you have the capacity to do a ventilator, you may have to set up an advanced airway for this patient. Now, there's a couple of different ways that you can do that, but the thing that's always on television and always that you think about is what's called endotracheal intubation. So whenever you're considering endotracheal intubation, there's a lot of reasons to do it, and there's just as many reasons not to perform this procedure. But let's assume that our patient needs this to be done. And so if we're going to go all the way to advanced airway, we're going to consider the ET tube. So this is called an endotracheal tube. It has two different ends and a lot of stuff going on, really. The thing that you notice is there's actually a little bulb on the end. And so whenever this is actually introduced, it can be held in place with a little bit of air. So there's a little tube here that connects to a syringe, and you can tell if it has positive pressure or not. This actually inflates as well. And this is where you would hook your bag or ventilator. So usually you take a 10 cc syringe. Let's see if I can do this. Take a 10 cc syringe, you push it, and it'll insufflate this. And so see how there's a little bit of positive pressure there. And that's going to sit in where the vocal cords are and keep this tube from being removed or extruded. Once that's in place, you can actually take one of these Ambu bags and hook it, and now you have the ability to breathe until you are able to get them to a more sustainable way of breathing for them. Or sometimes if you're on an ambulance, that may be all you've got. But a lot of times they'll have different type of ventilator support. The other thing is to make sure that it's going the right direction. You'll see that it has a pretty good bend to it. And that's because whenever you're looking at a patient, you're looking at them. So if the patient was in front of me, I've got their head this way, the nose is up, the feet are that end of the bed. I'm actually trying to introduce that into that airway, which is a little bit superior to the initial presentation of the esophagus. So I'm going in, sliding that in. Once I see the vocal cords, I go through those. I put my little syringe on, that's in place, and then I can start breathing for the patient. There are times where, say this person has a very large neck, or for some reason it's a difficult airway and you're struggling to get that airway. We use a thing called a bougie, or oftentimes we jokingly call it a hockey puck, because it's just a straight piece, silicone covered, it's not really a wire, but that's the only way I can really describe it. And it has sort of this hockey puck looking into it. So if you're struggling to get into an airway, you can use this to help drive where you're going. So I would use my, my device to try and open up the airway. I can kind of look around. I introduce this bougie, and what you're looking to feel are the what are called endotracheal rings. So these are the little ridges on the inside of the trachea that help support that structure, because there's always positive and negative pressure going across this, so it has to be rigid. Unlike the esophagus, which can collapse because we're not always, well, during COVID-19, I'm sure we're all eating, but constantly. But with the airway, this has always got to be rigid. And so whenever you introduce it, you're going to look and feel for these little clicks. And those little clicks let you know that you've actually introduced this little hockey puck, or hockey stick, excuse me, into the right area. You feel those ridges. All right, well, I'm in the right place. You bury this thing up. You can take your endotracheal tube, you slide it over this bougie, you push it all the way in. That should, if you've done everything correctly, put that tube into the trachea where you want it to be, put just past the vocal cords. You, see if I can get this thing removed, would remove this and then do your procedure normally. You insufflate that little bulb. Now that ET tube is secured, and then you can breathe for the patient. The other thing that you always have to worry about is they always talk about, or at least in emergency medicine, referring to protect the tube. And so once you place this tube, the way that you know it went through and into the right place is you saw it go in. The only way you know that it is going to stay there is if you don't let go of it until it is fully secured. There are several different types of devices that you can that can be purchased by your hospital or your service. And this will help secure that ET tube, or ET tube securing device. So on a patient, say I've got the tube in place, I would take this device, open it up, and I would slide it over the tube. So this would be if you're looking at the patient from overhead. I would screw that in place to cinch down the tube. And again, I'm never letting go of that. You slide this under the patient's neck and head and then secure it on the opposite side. What this does is help preserve the location of that tube. Now, if you're going down a bumpy road or if you're moving the patient from one gurney to another, that tube will not go anywhere. The patient's head has to come off before this will let go. So definitely something that's very, very important if you're in emergency service and you want to lock these down. And again, now you can either hook them up to a ventilator or you can do Ambu Bag and you can breathe for this patient. Just a few other sort of airway devices that are very helpful. If you have a patient that is spontaneously breathing, but say they're obtunded to some degree. So these are usually, I think about a patient that has had a lot of alcohol, they've had benzodiazepine overdose, someone who is maintaining an airway, but you really don't know, if this is going to be continued or not, or if they're going to be able to sustain that without a little bit of support. Or maybe you have a patient that is a little obtunded, but if you do a chin thrust on them, they can maintain that airway. So there's a few devices. One is a nasal trumpet, which can be introduced if maybe this patient has a lower mandibular injury. It's not something that I preferentially use, but the way that it's introduced, you actually do almost the same as intubation. The only difference is you use this through the nose. So you put a little bit of petroleum jelly on here, or you put some KY or something to help lubricate that. And then you actually do just the same way as you would your intubation. So that tip forms a little arc, so it goes down into the airway. And you're going to just introduce that into the sinus passage. And you push it all the way down. Once it's all the way down, you know that that is going to be in the appropriate placement for the airway, and you can actually use the Ambu Bag and that seal over this. So if this is on the patient's nose, you can make a seal on this, and that helps open that airway. Again, a lot of times that may not be possible just because if there is some maxillofacial type injury, but definitely something to consider. And then the other one that can be used for more of your obtunded patient that is spontaneously breathing, is maintaining their airway, you just need a little bit more security, or you haven't yet got all of your stuff set up to perform a true endotracheal intubation. You can use what's called an OPA, or oropharyngeal airway. This one, again, goes in the same place, same location of the mouth, just like you would introduce that ET tube. The difference is this is actually going to set between the teeth on the front of the patient, or the anterior aspect of the patient, but it's going to hold the tongue forward. And that's to help open that airway. It pulls the tongue forward to open that airway up and keep that patient spontaneously breathing. Now, these do come in various sizes. And so you really, whenever you're looking at them, you have to hold it to the side of the patient's face and see, okay, at the mark of the teeth, does it come down to the corner of the ear, angle of the mandible? If that is your position, you've got a good one. If it's too big, too small, you've got to change that. Very, very, very helpful though. One thing that we also talked about, and these are primarily for my students that have recently written prescription medications, talking about nebulizers, nebulized treatments. So a nebulizer or a machine for nebulized treatments, really all it is an air pump, kind of similar to what you use whenever you're airing up the tires in your car. It hooks to, you can hook it to oxygen, but most of the time you just hook it to air, a positive pressure on the wall. However, it doesn't hurt if you use it on oxygen. It's not going to hurt the patient. It's not dangerous. You just hook it up to some type of pressure device that will push air. You crank that puppy all the way to 15, which is usually the flow. So 15 liters per minute of either oxygen or air. And what it's going to do is push air up into this. And literally what this does is aerosolize your nebulized medications. And so I was using it for demonstration a second ago. There it is. So these are nebules. These are packets of medication. It has a certain amount of medication per concentration. So whenever we're talking albuterol, this is 0.63 milligram in 3 milliliter of fluid. So what you do is you tear one of these off. So we'll actually just pull one off. So they come in little packs. You take it individual, you twist the cap off, you squirt it in there, and then you put this cap on, And then usually there's a little mouthpiece that goes with it. I couldn't find the little mouthpiece, but usually there's a little mouthpiece that attaches to this. You just have the patient put it to their mouth. You turn the thing on and it starts making that fog that you remember for albuterol, or it's almost essentially humidified air, but it has medicine in it. They breathe in and out through this machine. If there's any air gaps, they're probably not getting all the medicine. But this is what you use whenever you're doing nebulized breathing treatments of really any type. Albuterol and steroid are not the only things you can put through them, but that's typically what we will put through them. Okay, so that kind of covers what I've got as far as general airway stuff. So I'm going to continue on, guys. So when we talk about medications, now there are things that you can give sort of in the acute setting. So whenever you're on a EMS service, or if you're in the emergency department. So again, my background is in emergency medicine, so I'm used to receiving these people, not so much in transporting these people to a service. So a lot of times whenever you see patients, again, I keep referring to television, but that's usually what a lot of people have had experience if you've never been in clinical practice. They always seem to have a bag of something hanging up on a big tall metal rack, and there's a bunch of IV tubing going in. Most of the time, that is just saline. So saline is just a type of salt water. The salinity or the natural salinity of your body is about 0.9%, which whenever you look at most of the medications or most of the fluids that we give, most of the time we're using normal saline or 0.9% saline. And it can come in anything from 250 mLs. This is a 500 ml bag. This one's a 500 as well, but they'll often come in a sealed bag like this. It's got two little attachments down here and a couple of different ways to manage. Most of them have a lure lock, and so you actually screw the cap on, but for demonstration purposes, this is what I've got here. And this would actually have the little needle cap that goes with it. So.
We have a question.
Yeah.
Well, two questions.
Okay.
One says, how do you keep track of everything?
Track of everything.
Yeah.
I think that was related to airway stuff.
Oh.
I think.
Magic prayer and a lot of practice.
The other is that so it's isotonic?
Yes, that is the correct word for it, isotonic. So there is hypertonic saline, which usually comes as a 3%. You can do some combinations of like a 1.5%, but usually whenever we talk hypertonic, we talk 3%. Isotonic is about 0.9, and then half normal saline is exactly that. It's 0.45%, which gives you more free water, which can be relevant in some situations. Now, to get into the argument about which one is most appropriate, that is about 10 lectures and a year's worth of reading, and then you'll still not have that exact answer. So unfortunately, that comes down to your practice and also whoever you're working with as an attending, whatever their preference is. There can also be combinations of dextrose and other things that go into the bags as well. So in this particular one, there's actually labeled on here as 5% dextrose. So that means there's 5% of this volume is actually a sugar component. And so in patients that are emaciated or they haven't had good nutritional status, maybe you've got to give them some calories, or maybe they can't eat at all, and this is all the nutritional status they're getting. So definitely there's a whole nother science to that that is probably not going to be touched today. So whenever you get these bags, again, you've made the decision that the patient's going to need fluids, or maybe you're in a resuscitation situation where they are requiring CPR and you're pushing fluids because that could be part of the problem. So you'll get these, there's a million different types of devices. In this particular setting, this is what I've got. It's a little plastic clip type, and you can hang these up just like that. And so the idea is that anything above a point, gravity is going to be pulling on it. There's going to be more force, and it's going to go downstream. So whenever you hear spike a bag, this is what they're talking about. There's a big spike that's on the end of this tubing, as well as a drip rate. So this actually lets you see how fast that volume is traveling. Otherwise, you have no idea how much fluid is traveling into the patient as time goes on. So you would just hook that to that spike, you shove it up in there, and now that spike is going to deliver the fluid and deliver the medicine or whatever happens to be in this bag. You give this a little squeeze to push air bubbles out. And before you ever hook it up to the patient, you want to run the air bubbles out of this. And so there's a lot of stuff going on down on this end. This is a little rolling lock that allows you to adjust rate or completely occlude that drip rate. Or so if you have a patient that's receiving meds, but you want to stop it, you can wheel that puppy down. Same thing with little line locks. You just slide it over and that will occlude that line and prevent anything from traveling through. You can also, once you've got this flush, so you let fluid run from one end all the way to the other end, you let a little bit dribble out, and then you can actually hook that to the patient after you clean their IV on their arm or in their AC, so in the antecubital space or wherever this thing may be. So once you've got that, say that you're pushing fluids, but you need to also give them a little more medicine, there's actually a little attachment here that allows for that. So say I've got to give it a little bit of atropine because they have a low heart rate. I can just hook that onto this. While this line is running, I can occlude this, and then I go ahead and push medicine that will run to the patient. I unhook it, and now I can run fluids again, and we keep on going. That way you're not having to start a new line for everything that you need to do. Sometimes you do start multiple lines. So a lot of times if someone comes into the ER emergently needing a lot of fluid or a lot of medicine or a lot of things, we may start 2, 3, 4 different IVs in this patient. There are other ways of starting an IV access, but primarily we're talking, or intravenous access, but usually we're going to use different types of IV catheters. So this is where we get into the angiocath versus the Foley Cath. So they're very, very, very different things. I'm going to start with the angiocath side, or what we often talk about, starting an IV or starting an IV in a patient. And there's a bunch of different types. There's a bunch of different sizes. The different types come down to whatever your hospital has made an agreement with whoever provides the equipment for your service. The sizes, though, that is something that you get to make that determination. If you have something that needs to go very slow or doesn't need a lot of pressure, or you're just trying to get meds in them, you can use something that's very, very small, something like a 23 to 24, 25 gauge. Whenever we talk gauges, the bigger the number is, for angiocaths anyways, the bigger the number, the smaller the needle. So they're also color coordinated. Yellow tends to be the 23 range, all the way down to a, let's see what we've got. I think I had a 14 gauge. So the bright orange one, usually the brighter they get, the scarier they are. The bright orange one is actually one that you can look down. You can see light down the tubing. And so very, very large bore. And so that's a 14 gauge. But what that allows us to do is the bigger that needle is, or the bigger that catheter is, the more fluid we can get to the patient faster. And so if you need something like a CT with contrast for looking at the lungs, so pulmonary embolus study, you need something to get there real fast. If you need something that's just standard, you can use a smaller catheter. If you have to give a patient blood, though, it has to be at least a 20 gauge or larger gauge, meaning 20 gauge, 18 gauge, 16 gauge, 14 gauge, to be able to give blood. Otherwise, it will damage those little red blood cells, and it's not going to be helpful or beneficial to give to the patient. So whenever you get these supplied, they come in these packages, as you can kind of see. You tear them open, and there's going to be the driver. So this is how you handle the needle as you're putting this into the patient. There's going to be a cap whenever you remove them, always away from yourself. And then there's going to be the needle and bevel, as well as the catheter portion. So this has got just a little, this is actually a pretty neat little device, and that's why I popped it open, because I wanted to look at it. But I know you probably can't see it, but there's a bevel to this. So needles aren't flat on the end, right? They have to have a point. To get that point, there's got to be sort of an angled edge. And the part that is facing the opening of that needle is called the bevel. You want that bevel to always face upward or towards you. That way you're not creating a coring, like an apple core. And that will reduce the likelihood that you have complications with the patient, with your device that you're using. So whenever you do this, again, we always talk about starting IVs in patients. You always see them on TV. They always go for this space here. It's great for drawing blood. It's terrible for starting IVs, but it's a space that you can do it. You put a tourniquet on a patient, you clean it with alcohol, you stabilize it, and then you're going to introduce this slowly into the skin, going towards a vein that you can feel. You always feel, you don't look, you feel. And then once you get a flash of blood, you'll see blood that actually is visible in this tubing here. You advance that catheter. Usually you just push it forward with your finger, drive it forward, and then when you pull this out, the needle is exposed. And really, I'm not sure if you can see it, but I always get excited about these. Can you see that on the screen? I didn't think so. Okay, well, I get to enjoy it anyways. So there's a little button here. And the reason that this tubing is so long, when you push that button, the needle drops down. And so that's to protect you from sticking yourself with a needle. These devices are actually designed most of the time to where, without really bringing a hammer and chisel out, you can't get to that needle again. Now, that's not entirely true. People want to mess with stuff, they can always mess with stuff. Now, the thing that's left inside the patient is actually not sharp. There's no metal left in this. It's not going to cause any more punctures as long as you place it appropriately. It also means it can kink up, or if the patient moves their arm or you don't tape it down real well, it can cause problems. But always remind your patients that, hey, there's no more metal in you. They'll always say, get that needle out of me. Well, it's not really a needle, it's a catheter. And this is an angiocath. Now, the second that you pull that needle out, there's going to be blood coming from this. So you want to occlude the vessel just proximal, meaning closer to the heart, along that vein that you found. That way it doesn't keep bleeding. And then you can attach your line, much like here. So this is what's still in the patient. And this is our fluids. And now we can run fluids in the patient. Okay. Okay, and so this is always the running joke too. So a difference between an angiocath and a Foley Cath. So a Foley Cath, so anything that catheterizes, it is a tubing or some type of device that it usually canalizes. So it goes into and provides some type of communication from outside to inside. And so where with most IV stuff, you can draw blood, you can give medicine, you can't take medicine back out. That's not how that one works. But with a Foley Cath, we are introducing this actually into the urethra. So we're actually going to use this to drain the bladder. There's some procedure that goes to it. It has to be performed in a sterile manner because you don't want to introduce any type of infection to the area. But the same concept. We have a location. We're going to introduce this. You put a little bit of gelatin onto this to help make its passage a little bit easier. You introduce that into the urinary bladder. There's a bulb on the end that you fill with either saline or air. Usually it's saline. And then you make sure that it's good and secure. What this does is it provides drainage from the bladder. If you've got somebody who has an enlarged prostate, if you have somebody who has some type of outlet syndrome where they can't urinate, you have someone who really can't, they are incontinent of urine and they're not capable of going for themselves. There's a lot of different reasons to do it. The other thing is if you perform this in a sterile manner, whenever you get that first little bit of urine, you get a very clean catheterization, you get a clean catch that's not going to have a bunch of microorganisms that are going to make your culture erroneous if you're needing a urine culture. So that's the difference between a Foley Cath and an angiocath. And so that has been Bruno's running joke for even whenever I was in school. So I always enjoy doing that one. So the other thing on urinary stuff though is, there we go, there's a couple of different ways to get these as well. So you can put in a Foley Cath that's going to be more long-term. It's going to last longer, it's going to stay longer. Typically you do have to change them out every few days just for cleanliness and sort of longevity if they have to be using it for a long time. There's been a huge movement to get away from using them for any longer than you have to. Sometimes it was the idea if you put a Foley Cath in them, then you don't have to mess with the patient as much. That's not good medicine. Don't ever do that. And there's a lot of standards by which remove that capacity. You have to have a very good reason to do that for a patient anymore. The other thing is if you've got a kiddo or if you have an individual in which you just need to get urine from them, you need a clean sample. Again, whether it's a mentation issue, if they don't have the ability to give you a good sample, they don't have the capacity to, it's a small child. There's a thing called straight cath. And so rather than introducing something that's going to stay there for a long time, that's very, very involved, In a clean procedure, you can actually do very similar with this device called a straight catheter or a straight catheterization. It does have little tubes up here, so if there's any material or debris in the bladder, you can, I never know if you can actually see what I'm doing. But it comes with almost like a little straw. And so this is actually introduced into the urinary, the urethra, and the idea is to get it up into the bladder. Typically, this is for small females. You can use it, however, on males just as effectively. Usually less so to adult males, but again, it's something that you can always try. It does have a little bit of adjustment to it. So if you need a long tube or a narrow tube based off of the particular anatomy and individual you're trying to get a sample from. And then there's also sort of a vial on this. It tells you how much you've got. So this would be introduced very similarly, very clean method. You put a little bit of lubricating jelly on the end, you introduce it into the urethra, and you're going to get a urine sample. And this is how you get a clean catch for children. If you're wanting something more specific, this is much better than catching in a hat, but sometimes it's not comfortable, and so you do your best is what you try. But this will give you a better culture if you plan to culture that out, and a better sample. So the other thing is, not all of your patients always need an IV. So that's assuming that we need blood or we need to give medication into the IV. Sometimes there are going to be situations just as simple as receiving an injection. And so in those situations, you can use varying sizes of syringes that come anywhere from TD size, which I know I've got one, but I didn't pull one out. So less than anywhere from units to 1 millimeter or 1 milliliter up to 60 cc and beyond. Really, it's just up to the imagination as to how big you want to go. Most of what I use in clinic on an average day is anywhere from your 3 cc to a 10 and 12 cc. And that pretty well covers the basis of most of what I need. If I've got an intramuscular injection, I'll use something that maybe it's a 1 milliliter that I've got to inject in a patient. Same thing with your needle size. The IVs, the angiocaths and the needles come in varying sizes and can be identified by the color. So this is going to be a 22 to 23 gauge. Now, the blue one is always the one that confuses me. So I've seen it labeled both. So most of the time they don't make 22s, they come in at 23. But that'll be your needle size. And then based on the type of injection that you're giving and the location, you may need a longer length, a shorter length, in different variability there. But if I'm going into a muscle, so if I'm injecting a muscle, I'm going to throw it like a dart and then aspirate. So I always pull back on the syringe, make sure I don't get any blood, because if it's not supposed to go in the vein, putting it in a vein could be a bad situation. And then you inject and then pull out. Always give them a Band-Aid because it makes them feel good. And then you move on. A really thick medication. So there's a medication called Rocephin that's an antibiotic. It's a very, very, very thick medication, and it'll never go through a little gauge needle. And so you really have to, you always have to apologize to those patients. Say, I'm so sorry, this is a thick medicine, it takes a big needle, bear with me. And most of the time people get through it just fine. And again, so this is just a 10 cc syringe versus a 3 cc syringe. So once you've used medication, so I know you've seen me cap this a million times, but you don't get to do this whenever you're out and practicing or whenever you're playing in medicine. So whenever you go to give an injection, you've probably already drawn up your medicine, or you've got a syringe full of medicine and a needle. You'll uncap it, you set your cap aside, you do your thing. So we've injected, we give that patient their injection. There are some devices, much like the angiocaths, that have a little lock that you push and it will cover the needle and it will protect you, just like this device from earlier. If that doesn't happen though, you should never put a cap back on a needle, because that only increases your risk of sticking yourself. Really, you should immediately take this thing, go to the sharps box and drop it. And whenever you're on the way, again, Professor Virali Claypool always has little things at the back of my head that I hear. And so she always says, hot sharps, hot sharps, hot sharps. And she's very vocal about having an uncapped needle and something in which somebody could be injured. And so typically what I will do is I'll hold it way overhead, because I'm not a tall guy, but most people are not taller than where I can reach. And so you're less likely to stick them. Now, if your butterfingers, don't hold it over your head either, because that could be a bad idea. So whenever we're talking about medications, the other thing is you've got to draw them up. And so medications come in a million different shapes, sizes, and formats. And I've got several here, but this is not all of them, and it's not even close. So the ones that most people think about are vials. And so these come in different concentrations based off of the type of medication that you're using in different formulations. So there's 1% lidocaine, there's 2% lidocaine, there's 4% lidocaine. And just because they all come in a 5 milliliter vial does not mean that they're the same. So whenever you're using these, some people will argue one way or the other. The way that I was always taught was this is a dust cap. It keeps the large particles off of the top of the vial. Whenever you pop these, though, you'll see that it's not a perfectly tight seal. So if there's bacteria, or if this has been dropped in water, or if this has been anywhere other than perfectly sterilized on the outside, there could still be stuff on top of this thing. So you really should always use an alcohol swab or something, even after you've uncapped something. Some people will argue with you. Again, that's just my practice. Do what you will. So whenever you're drawing medicine up, if it is a one use only, all you have to do is find a way to get the medicine out of the vial. And usually I will actually switch needles. I'll use a larger bore needle to go into the vial, draw up my medicine, and then switch it out. That way I'm not using a needle that's already been used on a patient. That just helps that that's a fresh needle, it's never been used, meaning it's going to be sharper and it's going to cause less pain to the patient. Sometimes it's not a big deal, but sometimes it is, depending on what you're using. The other thing is, a lot of people if it's a single-use vial, you can introduce air into it. So you can put a little bit of air in there, and that'll push that syringe back out, and you'll get more of that medicine out a lot easier. If you stick a needle in here and you're pulling, it may take a little bit more work if it's a glass vial. The one thing you don't want to do is, if this is a multi-use vial, so something that you plan to go into more than once, you always clean the top, always. And then don't introduce air if you don't have to. So any air that gets sucked in there, there's nothing you can do about it. But if you're taking a big old blob of air and you're shooting in there, you're actually increasing the risk of cross-contamination. You could introduce some bacteria in there, it could start growing, and then the next patient that you inject that into is going to have some bad stuff happen. And so that's just a precaution thing. Again, that's what I think about whenever I use medication each time. There's going to be variability whenever you're in practice. There's going to be variability when the docs that you practice. The only person that can have a bad outcome is your patient. So think about them first, and you'll never do wrong. Also, vials that have a red top on it, it's always red for a reason. That means that there's something very, very important to know about what's inside of it. So this medication, usually you see red and you think of like epinephrine, which that's not something you want to just inject anywhere and everywhere. So use caution. In this one, this is succinylcholine. So this is a paralytic agent. If you were to inject this into a patient, they're paralyzed. That's a bad thing, because one, we got to wait for it to wear off before they start breathing again. And until they start breathing again, you got to do it for them. So anytime it's a red top, use caution, but also always read what you're using. I mean, if you're always reading the label and seeing what this is, you're never going to go wrong, because it doesn't matter what color the lid is. The other thing is, if you did not open it, I would not use it, because you don't really know what someone else has done. Did they introduce some air? Did they introduce something that doesn't belong there? You have no way of knowing. Same thing with the syringe that's already filled with medicine. You might think you know what's in it, but you might not. Okay.
Mm-hmm.
So sort of the last thing on drawing up medicines, the other thing that you probably will see, and in fact, I see them mostly in lumbar puncture kits, is vial medication or ampules. And so an ampule is a vial of medication. This is entirely made of glass, but it is stored along this little blue line. And so whenever you have these, I typically see it as lidocaine, but there's a couple of other medications that you can find. And again, these are typically in my lumbar puncture kits. So whenever you're using these, first you have to get to the medicine. So the thing that you do is you either take an alcohol swab or just one of the packages, or you take some gauze or something, and you grab each end and you break it away from you. And the idea of breaking it away from you is, if there's little tiny glass shards that pop off, it's not going to go in your eye or get anywhere on you. So once that's there, now you have to draw up the medicine. Historically, there were not filter needles, but nowadays we don't have to worry about that. So you would break this, suck up some medicine, and then stick it in somebody. Well, they got to thinking about that, and it's like, well, that could be dangerous, because what if we throw in some glass shards into a patient? So there are filter needles, and they specifically say, and usually they come in a red package as well, kind of like that, so you don't accidentally stick it in a patient. You'll put it in here, and you can actually hold it upside down. The vacuum that's created by this, the medicine won't fall out, and you draw that medicine up. Historically, if you didn't have a filter needle, you would hold it this way. The idea is that the glass particles sit down at the bottom, and you draw from here, and you just don't get that last little bit, and you're less likely to throw shards. But with a filter needle, it will actually filter out those particles smaller than a certain micron, and it'll have that on the package too if that's irrelevant or important to your practice. So what you would do after that is this is a shard. Glass is sharp. You throw it in the shards. And then you would get rid of your filter needle, put on a new needle, and then you're going to inject however you're going to do with your patient. So again, just different ways that medication is presented. There are also, in the emergency setting, if you're in a code setting where you need epinephrine, so an ampule of epinephrine, or you need dextrose, you have these packages in your crash cart that just look crazy. So I'm going to crack one of these open. So this is 50% dextrose. So this is actually a giant glass vial. And so what you do with these is all the stuff that you need to give the medicine is in here. And I'm probably going to embarrass myself not being able to figure out how this one works. Every one of them works differently. So if you're at a facility that you've never used any of this stuff, you've got to figure it out. Okay, this one's not that bad. So this actually has the administration device and the vial of medicine in one setup. So it's got a little cap here. You actually screw this on, and there's a needle here that actually punctures into the rubber here. And so this turns this into a giant syringe. You would take this off, put this into, yeah, that's right. You never give this straight to your patient. Don't stick this in a muscle. They'll be very, very, very mad. And then whenever their arm falls off from the hypertonic setting. So this is not typically something that you see anymore. This is really, most places have gone to a needleless setup. And so this would actually screw onto this lure lock here. But if we were back in the 90s, it was 2000s even. It wasn't too long ago, really. You would actually put this through one of those little rubber caps. This is right here, and you just push. So you push this hard and fast most of the time. Again, it's kind of at the direction of the provider, which you guys will be the provider or up and coming, right? And then again, don't cap these. This would also go in the sharps because glass needle, this actually has two needles, again, because this screws together to make one unit. And so that's your syringe. Don't stick that in your patient. It even says on the package, don't put in your patient. So that's dextrose. The other one that you see, and this is one that you typically will use in a code situation, and this needs to be timed, and this goes along with what's called Acls Protocol. It's got a cap. You always know the ER guys from the other guys. I tear the box open, and the ICU guys are like, oh, not pretty. So same device, same setup. So again, if this was, back in the 90s, whenever we still used needles, this has a needle on this end, a needle on the other end. You would uncap the medicine, screw this on, and then you push your medicine. Another thing to note is, so I keep making these jokes about old school stuff. I know you can't see it, but as medication ages, it's got a shelf life, just like the food in your cabinets at home. And if you go over the shelf life, there's a risk that it can no longer be sterile. That's the only amount of time that can be guaranteed to be sterile. After that, you're kind of at the mercy of everything. I know you can't see it, but there's little chunks of stuff floating around in this, and I just pulled it out of the box. If you ever see chunks of things floating around in any medicine, never, ever, ever put it in a patient. Ever, ever, ever. In nuclear medicine, it's a different story, but that's completely different. So that's a different world. So, and those are kind of your emergency type medications. Now, again, different devices look different. And so this is dopamine. Same idea. It's got a little cap that screws on. This doesn't have the same needle. Well, yeah, it does. It's got a needle device on either end. Again, red, always look and make sure. And it even says must be diluted, not for direct injection. So you don't give this straight to your patient because that's not how you make friends. Let's see what the Glucagon Kit is. Okay. So if you have any diabetic family or diabetic friends or anything, there are oftentimes, especially type 1 diabetics, they can actually have an issue where they overshoot their insulin or their blood sugar gets very, very low, and they'll have these little glucagon kits, and usually somebody around them has been trained to, or maybe if you're the one that they trust, you may be trained to use this as well. The Glucagon Kit has a couple of things in it, and they're all different. Most of them nowadays have changed a little bit. This is the diluting solution. Okay. So in this setting, this is actually the diluting solution. You would either do one of two things. You would shoot this down into a vial, which this one is. This is lyophilized. So there's a powder in the bottom of this vial. So you would pop the top on this. You would use this, shoot it in here, and then mix it. Never shake a bottle. You always stir it, because it can make bubbles. You can lose some of that medicine. And in a glucagon kit, you would draw that medicine up either with this syringe or a different syringe, and you actually just put that into the thigh muscle, and then inject it. What that's going to do is help start a process of increasing that blood sugar through a pretty involved gluconeogenesis and glycolysis. I have to think out loud. But if you ever see these kits, one, if you prescribe these, so to my students that are actually going to be prescribing medications, make sure you teach not only the patient how to use this, but at least one family member. And that way they know what to do with it. Because if you just send this medication and say, good luck, you know, even I have to look at it each time and see, okay, well, what do I do? There's a little bit of instruction here, but in an emergency situation, you don't need to be figuring out how to do something. So.
We have a question.
Okay.
Why the thigh?
Why the thigh? Because it is the easiest target not to damage things. It is literally for folks to be trained to do it easily. Anytime that, if you think about epinephrine, we tell them stab them in the thigh too. You're less likely to hit a lot of high dollar real estate. When we give injections in the shoulder, when we give them in the hip, we know where we're aiming. If you get a mom or a dad or somebody who's trying to take care of their kid and they stab them somewhere and they inject this medication, if it is over a nerve or even worse into a nerve, they could actually cause permanent damage. So imagine you're just trying to get your kid's blood sugar to go back up, and now you've paralyzed them from the leg down. So usually, and there could be changes over time and based off of type of medications, usually this and epinephrine for like anaphylaxis, it goes in the thigh. That way you're not going to hit anything bad. And it's a big target. It's bigger in Oklahoma too. So.
And we have one more.
Yeah.
Is stirring the medicine the same as rolling the vial between your hands?
Yes, pretty much. So you can spin like that. You can roll like that. Just don't do this, because even something that doesn't have powder in it can start foaming bubbles, and you're losing medication. For every bubble you've got, there's medication floating on top of it, and you'll never get that into a syringe, unfortunately. Good. Okay. So just looking over the last of my stuff. I think I missed two things on needles and then blood cultures. So I'm going to roll back just a little bit, because I'm in all my chaos that I've got going on over here. I've missed just a few things. So going back to needles and needle gauges, the one thing that doesn't really follow the pattern of, you can look at the color of it, at least in olden days. Nowadays, they're a little more often colored, is whenever we look at doing what's called a lumbar puncture. So if there comes a situation where a patient has concerns that there could be either blood in the CSF, so the fluid that goes around the spinal column, or the spinal cord, or maybe they've got an infection that we're trying to figure out what's going on, and we need to sample that. The only way to get a good evaluation of that is actually to take fluid from that space. To do that process, it is procedural, and I'm not going to get into that. I just want to show sort of the devices that you use. You would numb up the back though, make it perfectly sterile because you do not want to introduce anything bacterial or pathogenic into that space. And you have to use what's called a spinal needle. And so these are actually a long needle. This is typically how they're supplied, usually in a kit or a case that you just open up and everything is there, but sometimes not everything is there. And oftentimes if you open it up and it's meant for normal average people and you've got, you know, a big Goliath guy in there, it may take a longer needle to get in there. So here's roughly an average size spinal needle, which goes to about there. So you've got about, I don't know, we'll call it about 4-inch or so of needle. And usually that's sufficient. Oh, that's actually, it says right there. So it's 2.5 to 3. So usually that's sufficient in smaller folks to do just fine. But oftentimes in the ER, we've got larger needles, larger gauge. These can be anywhere from 23 all the way up to 18. 18 is huge. The biggest I've ever used on a patient was a 20. And it was for this reason, is because if they're really, really big and you've got a lot of back to get through, you can use this thing that most people call a dart. And so this is a spinal needle, and it has 2 parts. So it's the needle portion, but it also has this center core that is used to sort of stabilize and strengthen it, but also to occlude the bevel, the needle bevel. And whenever you're introducing this, the last thing you want to do is create sort of that apple core thing that I was talking about. And that's really what that device is to do, to one, prevent that from occurring, which can also secondarily cause a continuous CSF leak. And so if you create an apple core, you imagine taking a bit of tissue out and you core it out, now you've got an open communication of CSF out of the body. And so in those situations, people either have to have surgery or a blood patch, or there's a lot of complications that can go through it. So whenever you're using these, make sure you always have that center piece involved. Whenever you're using these, there's also a little notch, and I know you can't see it, but there's a little notch to where it locks. So you can see I can spin that inner core and then it locks in place. That's how you know that that core is flush with the bevel. And then whenever, and this is more for my students as well, whenever you're introducing this needle, you actually want the bevel to be up, but a lot of times your patient will be on the side. And the idea is that if it is cutting this way and the, excuse me, I said it wrong. The bevel's up while they're on their side, because if it's cutting this way, those little cauda equina, so those thin tendrils of the most inferior portion of the spinal cord, is going to just push out of the way. If you've got it turned, you know, up towards the patient and it's cutting this way, and you've got lines going this way, you're more apt to cause local injury. Again, usually a very, very safe procedure, but only if you do it correctly. But again, that's a spinal needle. Now, also for those that whenever we talk about pericardiocentesis, and this is one that we had mentioned as well, this is what you're going to use. You're going to use the dart. You're never going to use the little baby one. You'll never make it to the heart. So in those situations, you actually take that center core out. You get a bigger one than this, but you get a large syringe. You attach it to it, and then you're going to perform your procedure. And that's actually something that you guys will be introduced to kind of moving forward. But really, if you're not using a large bore needle and one that's really, really long, you'll never actually make it to that pericardial sac. So something to think about. So another procedural intervention is whenever we take a thing called ABGs. Now, this is a little bit different, mostly because of technique, less so of the equipment. Although the equipment that a respiratory therapist uses to retrieve an ABG, which they're the ones that get the cool stuff. So,
what does ABG mean?
Oh, arterial blood gas. So arterial blood gas is going to help you identify pH imbalance and also identify bicarb. Those are usually the 2 most important things. You can get other information like your oxygen concentration, saturation on the arterial side. But really, whenever I'm looking at those, most of the time I'm looking at 2 values. I'm looking at a bicarb, I'm looking at the pH, and then really the CO2 is important in respiratory patients, but I just never get respiratory patients, so I always forget about those values. So just like your angiocath. So an angiocath means angio means it can go anywhere. It can go arterial or venous. Most of the time, though, we're going to introduce it into the venous side because that's where it's easiest. You have less risk of problems following the procedure. You have there's really not a lot of reasons to get an arterial sample unless you absolutely need it. So an ABG is one of those. That's what you do. Most of the time, the easiest access you're going to find is going to be in the radial aspect or the ulnar aspect at the wrist. There's a thing called an Allen's test that an RT or whoever the provider is going to perform, in which they look for possible occlusion of this. And again, students may or may not have already seen this, but it is a procedure to do before doing the procedure. Whenever you're doing this, you actually introduce it as a 90-degree procedure. So it's almost like going for an IM injection. But the difference is you're feeling for that radial pulse and you're going to the radial pulse and you're going straight down. Because of the positive pressure, the amount of pressure that comes from the arterial blood flow, most of the time it'll actually push this little syringe up. You don't have to draw it. It'll actually push it up. And then whenever you get to a certain point, you will withdraw that needle, you apply pressure, and you actually have to apply pressure for a long time. Most of the time, it's anywhere from 5 to 15 minutes based off of what your protocols are. I know people who slap a gauze on there and don't really practice good medicine. So you really should apply pressure for at least 10 minutes to make sure that that occludes. The idea is that if it was a venous bleed, so like a cut or you cut a vein, it doesn't take much pressure to occlude that, and you get the fibrin build up, you get the clot that forms, and then you're good. The arterial side, though, it takes a little bit longer for all of that to coagulate. If you pull your thumb off there too quick with the gauze, they'll start spraying everywhere, and then you got to start all over. So always apply pressure after you've punctured an artery, and for the most part, you really shouldn't be puncturing arteries unless you absolutely have to. The only other thing that I've got, and I forgot to mention, and these are very important with your really, really sick patients, is you'll hear a thing, and some people may see these, it reminds you of little Coke bottles, or at least from my childhood. And so you will need to get blood cultures often in patients, and these are your patients that come in with a fever, they're septic, you think that they could have some coronary vegetation, they're IV drug users. For whatever reason, you need to find out if they've got bacteria in their blood that's making them sick. And so really in blood cultures, there's a specific process in which you have to do this. Most of the time you do them in separate arms, you do them on separate sticks because you want a diffuse sampling. And so this is a very, very important process, and it's actually a very expensive process too. So you really got to know if that's what you need to do for the patient. 2, don't be doing this in your clinic, because if they're sick enough to need blood cultures, they really should be admitted to the hospital, which has been my ER practice as well. If I draw this on you, you're not going home today. You're going to stay with us in the hospital until we get these results back. And what this does is whenever you draw the blood, it goes into 2 samples. You usually do 2 at the same time. And so what that does is give you good sampling. That way, if one of them is bad, you've got another culture already cooking that could give you different information, and then you have to compare the 2. That helps guide your antibiotic therapy, your other regimens moving forward for a sick patient. Of course, we have to get them out of the ER and safely up to a room to where they can be managed. So my mentality is always take care of them now. This is kind of at the back of my thought process, but something that still has to be done primarily with those patients that qualify for septic workup.